So thanks for being here. Our program has been in existence since June of 2002, so we've been here for 13 years. And we're one of 5 level 4 epilepsy centers in the state of Florida, which is the highest level recognized by the National Association of Epilepsy Centers. Now, I'm going to go through a lot of information, but really in a kind of a cursory way, because there's a lot of information. So the goal is for you to just kind of get a bird's eye view of developments. And then there's a part on diagnosis. I'm not going to go through the different seizure types. They're in your handout, and in terms of how seizures are classified, but I'm not going to go through that because there's not enough time for that. Now, with regard to advances in diagnosis, we'll talk about video EEG monitoring, why it's important to do a specialized MRI epilepsy protocol, and then different MRI techniques like voxel-based morphometry, and I'll translate that into English for you, and then PET scan, positron emission tomography. And then in the handout, there's some information learning about epilepsy and seizure symptoms, which I won't go into. However, we will talk about the importance of getting an accurate diagnosis. Accurate diagnosis is key. And then also the studies that are essential to understand epilepsy, and also know what to do when seizure medications don't work. And also to understand, once you've failed a certain number of epilepsy medications, what's the chance of becoming seizure-free? And then also what's important is to learn about currently available therapies, because sometimes people are seeing neurologists and there are older therapies and not necessarily newer therapies that may be beneficial. And then there are also a number of therapies that are in the pipeline, which may be a benefit to you in the future. And then there's also newer cutting-edge diagnostic methods that are in development and also currently available, and even seizure detection methods to be able to better recognize seizures. So to start, what is an epileptic seizure? So our brains have about 60 to 100 billion nerve cells, and they all kind of communicate with each other. And when they're functioning normally, they allow us to think, they allow us to see, they allow us to communicate, allow us to have feelings, etc. However, when some of those nerve cells are not functioning normally, then that's what produces an epileptic seizure. And they communicate through electrical and chemical signals. So the electrical signals are sodium that goes into the neuron. So it's not like the same as the sodium that's in your bloodstream, but sodium goes into the neuron, it gets activated, goes down the neuron into the synapse, then releases the chemical, and then the chemical communicates with the other end of the neuron to produce a response. Now, some nerve cells tend to excite, and some try to tone down activity, but there's a fine balance between the two that allows our brain to function normally. However, if the brain chemicals that excite are a little bit too high, and those that kind of make things quiet, inhibit, is too low, then that can be the perfect storm for producing a seizure. Now, an epileptic seizure occurs, and this is why an epileptic seizure can occur in anyone. So in the right circumstance, almost anyone can have an epileptic seizure. So there's some people who have what we call provoked epileptic seizures. So if your serum sodium level went down really low, or if you got a certain medication, certain antibiotic, or if you had a certain infection, you might have a single seizure. What happens during that time is that a number of neurons start firing very fast, faster than normal, and there's a cascade effect, and then it ends up producing a seizure. And seizures come in a variety of manifestations. It can just be a feeling. It could be just seeing something, some intense feeling, lasts seconds to a minute or two. It can be a loss of awareness, unusual behavior, but it's typically the same thing every single time that it occurs. And then if it progresses, it goes into a generalized tonic-clonic seizure, which is a grand mal seizure. One of the problems is that some patients' seizures are kind of subtle. It's not uncommon we see people who, one, don't know they have epilepsy or have seizures because the seizures are so subtle they don't know that they're actually seizures. Or we see some people who are only counting the convulsions. So they say, well, I only have 2 convulsions a year. I have these other attacks, but that's just anxiety. And then when we talk about it, we end up finding out they're having seizures 3 times a week or sometimes even every night, et cetera, and they didn't know that they were seizures. But with the seizures, that same network that gets activated every single time, and it produces the same symptoms. Now, the question is, why is it important to diagnose someone with seizures? Well, first of all, they can be disruptive because even if you don't lose awareness, they They oftentimes disrupt one's feelings. You have to stop whatever you're doing when they're occurring. But most seizures cause loss of awareness, so loss of memory. So obviously if you're driving, that's a problem. Or if you get confused and you lose awareness and you cross the street when you're not supposed to, you can get hurt. And then also, uncontrolled seizures have other adverse effects. Not just the seizures themselves, but they can have an effect on our mood, cause depression, anxiety. They can affect our memory, attention, concentration, all of those things. And then in some cases, uncontrolled seizures can also lead to death, a phenomenon called sudden unexplained death. And that's why it's very important to be able to diagnose seizures and epilepsy accurately, find the right treatment, be aggressive, not be complacent. The goal is to try to hopefully eliminate the seizures, or if we can, minimize them, and then wait for future developments such that we could potentially eliminate the seizures in the future. And this is just a schematic showing, and actually neurons are more dense than this, but they're kind of all interconnected, having a domino effect, and this is at the end portion of the neuron where the neurotransmitters are stored, and then they're released and either tamp down the activity in the neuron it's communicating with or increase the activity. Now, what is epilepsy? Okay, so a single seizure is not epilepsy. Epilepsy is a condition that causes recurrent seizures that's not provoked by anything. Obviously, sleep deprivation and stress can affect seizures, but that's not in and of itself the cause. And so, and the term epilepsy is, all it means is a condition that causes recurrent unprovoked seizures. And it's a term that's over 2,000 years, comes from the Greek called epilemnium, which means to be overtaken. So obviously, if you see someone having a seizure, particularly a convulsion, it looks like the person's being overtaken by something. But actually, epilepsy has been described even going back to 5,000 years ago. They can see it in ancient writings. So really, anyone who's had 2 or more seizures, or 1 seizure, and either an EEG or MRI that tells us that they have a high risk for having further seizures, typically a 50% or greater risk, then we call that epilepsy. And there are about 3 million people in the US with epilepsy, and 1 in 26 people in their lifetime will have epilepsy. So that's not 1 in 26 people have active epilepsy, but 1 in 26 people will either have epilepsy or have had epilepsy at some point in their life. And epilepsy is the 4th most common neurologic condition. Now, some of the important other things about epilepsy is that 16% of epilepsy patients are not on a seizure medication. Hard to believe. 1 in 3 patients with epilepsy have not seen a neurologist or an epileptologist. Or some people with uncontrolled epilepsy are just seeing a general neurologist. And if anyone has failed 2 or more medications, you really need to see an epilepsy specialist, because that means your epilepsy is more complicated and needs special attention. Also, epilepsy costs our country a lot of money in terms of hospital costs, but also loss of employment. So it ends up costing our country roughly about $15.5 billion each year. There are a variety of causes for epilepsy. Sometimes we can find it, sometimes we can't. And when I talk about MRI, this is where the MRI is very important, right? And our staff oftentimes have to explain this to our patients. Because it's not like doing a quick, 15-minute MRI. I mean, that's good if you have, not that you want to have a big tumor or stroke, but it's good for finding big stuff. But with epilepsy, we're looking for tiny stuff. And that tiny stuff can be very important because it can tell us the chance of controlling your seizures. And for some people where the seizures are not well controlled, surgical therapy, or it can even tell us that there may be a genetic cause for the person's epilepsy. Now, accurate diagnosis is very important. It's not uncommon that we see people and they have the wrong diagnosis. They don't even have epileptic seizures. Or they have epileptic seizures in another kind of episode. They have a cardiac condition or a condition called psychogenic non-epileptic seizures. Sometimes they have both. And it's very, very important. Also, accurately diagnosing patients is important because, it empowers families. Because what happens is if a family knows what's occurring and they know what to do, then they feel more in control. Okay, this is their focal seizure where they do X, Y, Z. This is what you need to do. Oftentimes I ask families, take a video of the events so that I can see it on video. Okay, it's not as good as having the EEG, but having the video can provide valuable information. I had a patient a few months ago who showed me a video of her spouse, and he had two different kinds of seizures. One was a blank staring spell that looked like a temporal lobe seizure, and then another one, we had rapid facial twitching with a lot of saliva, which immediately told me that his seizures may be beginning in one area, but they were spreading, and so the whole hypothesis about his seizures changed. Although I had an idea of where his seizures were occurring, but the video was really key. And now with technology, it's great because, if with our cell phones, you could take a video of the seizures, bring them in. I've even had some patients actually upload them from their iPad to the cloud and then bring in the seizures, and we're able to see the different seizures on the video. So, the key thing is when we work together, see, part of working is not just me telling you. Of course, I have the knowledge, I can tell you what your diagnosis is, what the cause of your epilepsy is, but it's really a partnership because the goal is, my goal is to teach you what to look for so that, because you're the one having the seizure, family members see it, right? So if you know what to look for, then you almost become a mini neurologist because you know what to look for, then you can tell me. That information helps me figure out where the seizures come from. Sometimes patients have been telling the neurologist for years where their seizures are coming from. And then just by listening, moving close and listening, we figure out that, oh goodness, that's where the seizures begin. Something as simple as tingling in the foot and it goes up my leg. We had a gentleman like that with seizure surgery twice, last time in 2011. He's been seizure-free for 4.5 years. And just based on his aura, we were able to localize the seizures. Of course, we had to do more sophisticated studies, but we were able to actually move to surgery. And it's also important, a good number of patients have seizures and don't recognize them, okay? So for example, if we look at the case of temporal lobe seizures, that people with seizures come from the right temporal lobe probably recognize that they've had a seizure maybe 50% of the time. People with seizures come from the left temporal lobe maybe recognize that they have seizures 10% of the time. So 90% of the time, they don't even know they're having seizures. And it's not uncommon, we'll do an EEG that someone wears for 24 hours. We say, you have 2 seizures. Did you know? They had no idea. Sometimes we even have someone in our office having a seizure, and after the EEG's over, or even the next visit, I says, remember you had the seizure during your last visit here? I had a seizure during my EEG. And so what happens is, oftentimes seizures are unrecognized, but if we educate your family what to look for, then we know that you're still having seizures, and then we can adjust your therapy accordingly. So one of the steps that we do this is video EEG monitoring. We've got specialized equipment to do this. So sometimes we'll do outpatient tests like a routine EEG or what we call an ambulatory EEG that you take home with you, and we record your seizures. And also we have the ability to actually do home video EEG now. We have that equipment here at Bayfront now. But video EEG monitoring in the inpatient setting, what happens here is that you come into the hospital, we lower your medicines, and when we try to capture your seizures, but what's very important is that video EEG monitoring has to be done at a specialized epilepsy center. It can't be done at some fly-by-night place because first of all, you're coming off of medicines and you have to be in a safe environment. And secondly, we're getting the information to try to figure out what's going on. It's not like passively, okay, go in the monitoring unit and then let's just see what happens at the end of the week. It's an active process where we're looking at the data, our EEG technologists are looking at the data, the nurses are coming in, asking specific questions that's helping us figuring out what's going on. And one of the dangers here, and just to let you know, there are places out there, and sometimes even neurologists that are trying to do this in their office. In some cases, you could potentially do video EEG monitoring in an outpatient setting, but in very, very discrete situations. But really, it needs to be done in a structured setting. It's not something you're going to do complicated video EEG monitoring in someone's office, or someone's going to come to your house and do it. There are certain situations where that can be done, but it's not going to be done correctly. Or if you're being considered for surgery, definitely not. It can't be done that way. And it's important to have people who know what they're looking at. So board-certified epilepsy specialists. So we have 2 board-certified epilepsy specialists here, myself, Dr. Zimba. We have superb EEG technologists who also look at the data, registered nurses who are trained. So they're superb nurses, and they're trained. They know about seizures, and they can help educate you about seizures. And clear data review, because the key thing is that a general neurologist is not going to be able to look at that data. The data is way too complex. And most general neurologists get 6 to 8 weeks of EEG training, right? To give you an idea, I trained at UCLA, so everything is epilepsy at UCLA, all right? So finished neurology residency, And I says, gosh, I started my fellowship. I'm all ready for epilepsy. I know my epilepsy stuff. And then first week, it's like, oh my God, I don't know anything. And then started another 2 years, starting from scratch, realizing how much I didn't know. And even today, each time we bring a patient to the monitoring unit, we constantly learn something new. Because you just have to keep an open mind, because there's always something to know. But the key point is, don't be fooled. If you're going to get video monitoring to try to classify your seizures or determine whether you're an epilepsy surgery candidate, has to be at a place that is specially trained. Otherwise, you're wasting your time, and also it could be potentially dangerous. Now, another important thing is MRI is incredibly important. All right. So the MRI produces a picture of your brain by taking slices in different planes. So it'll take slices in this direction, and this direction. And the key thing is the thinnest slices as possible with the greatest resolution. So typically a good MRI takes a lot of time, so it takes about 45 minutes in the scanner. I mean, you have to stay still for 45 minutes, but each sequence, the longest sequence might be maybe 10 minutes. Years ago it used to be 12 minutes or 14 minutes, but now it's down to 10. So you have to lie still during that 10-minute period, but it gives us fine anatomic detail. The other thing that we do here as well is not, we just don't kind of say to the neuroradiologist, okay, set up an epilepsy protocol and run with it. Yes, we work with the neuroradiologist, but we're on top of that protocol to make sure that it's the right protocol. And we look at the images, the neuroradiologist looks at the images, but we look at the images, and we correlate, we know where to look in the brain based on what we see in EEG and based on what you're telling us in terms of your symptoms. And then there are other studies that we do, particularly for people we're considering for surgery. SPECT scan, when someone has a seizure, blood flow increases, and then that can help localize where the seizures are beginning. PET scan, measure of how your brain uses blood glucose, and areas of the brain that aren't working too good show reduced glucose. And then a test called magnetic source imaging that looks at the magnetic field of the electrical activity in the brain that helps us localize your seizures. All right, so right now, the first part was talking about defining seizures, epilepsy, and why it's important to get accurate diagnosis. All right, and why it's important to get people seizure-free, and video EEG monitoring, MRI. And so one of the things that we do is we pay attention to detail with our video EEG monitoring, EEG, clinical history, and then also MRI, looking at the data and then pulling it together, try to figure out what's going on. And what we'll typically do, because it's not just physicians, but it's also the staff, e.g. technical staff, the nurses, and also my office staff, to kind of walk you through the process. It's not just the goal of like, give you a prescription, go get your test done, because it's not gonna happen. But them actually scheduling it, making sure it occurs, and explaining to you why it needs to be done, because the tests are very specialized and has to be done in the correct way. Because the goal is not just to check, let's get the test done and it's done, get the right test so that we can figure out what the problem is. So what I'm going to go through next, and this is going to be a whirlwind, I'll go through this quick. Don't worry about trying to understand all the details. The goal is just to give you an overview of where epilepsy treatment is going and epilepsy diagnosis. And really this is an exciting time because there's so much going on that offers a lot of hope for finding a cures for epilepsy, better ways to identify seizures than we've ever had before. This is a quote by William Lennox, who worked with actually Gastaut. No disease is more intriguing, more protean, more pressing for a solution than epilepsy. In other words, more protean, just having so many different features that it can easily confuse you. I've been doing this for 20 years, and I get confused a lot with different kinds of seizures because of how they manifest themselves. It is not to be imagined that he should know the remedy of diseases who knows not their original causes. And our goal is to really find the causes, and certainly with what we know about genetics of epilepsy, we're learning a lot about that, and we're learning about MRI, and also what we're learning through electrical data. We're really learning a lot, quite a bit about epilepsy. And actually, the more we learn, the more complex we realize how epilepsy is. Now, we've come a long way because greater than 100 years ago, so actually in 1916, or 1919, depending on where you read, the first treatment for epilepsy came out. That was phenobarb. All right, so before 1916, guess how many treatments there were for epilepsy, or at least bona fide treatments for epilepsy? None. So, however, and this is the bromide tower in Baltimore, that they use bromides for the treatment of epilepsy. The only problem is, they don't really work and they've got side effects. They even use digitalis, which is used for the heart these days. And if you get toxic, you start seeing halos. I ever saw Van Gogh's Starry Night. Well, it was felt that he had seizures and he was taking digitalis, and they're speculating that he saw halos around lights. I don't know if that's true or not, but we've come a long way, because just imagine 100 years ago, no treatments for epilepsy. In fact, they didn't even know they were epileptic seizures. And in fact, many people with epilepsy ended up being in epileptic colonies. So here's a history of treatments for epilepsy. And actually things have changed a lot in 20 years, because up until 1993, so the first newer epilepsy drug came out in 1993, which was felbutol. Prior to that, we didn't get a new epilepsy drug since 1978. And so in the first, 84 years of the 20th century, these are the medications that we had. There's a couple others in there, Salantin, which I'm not in there, but for the most part, we only had maybe 6 seizure medicines to treat people with epilepsy. Now, actually, one other thing, too, is that epilepsy has actually become something that people are fascinated by, that actually neurology residents want to go into epilepsy. Before nobody wanted to go into epilepsy, because, what could you do? In fact, my first epilepsy meeting in Miami in 1983, there were 900 people from all over the world that came to the epilepsy meeting. 900 people. It was at a hotel in Miami. Now, it's anywhere from 5,000 to 6,000 people. And then this is some of the newer medications that have come out, and there are even newer ones than this. And then these are some of the newer ones. Vimpat came out in 2011, Aptium, escarbazepine, Onfi, Propranolol, Brivaracetam, recently approved to be available probably in January or February next year. And then this is just a schematic. I alluded to this sodium channel. And some of the drugs we actually work through sodium channels. And so this is our nerve cells have these membranes. Here's a pore. And sodium goes through that pore and activates the neuron. And that's when it gets hyperexcited. But if it gets too hyperexcited and then rapidly, repetitively firing, that's what causes the seizure. Some seizure medications actually block the pore selectively when the neurons are misbehaving, less so when the neurons are doing their normal thing, like listening or talking. All right. Now, some of the newer anti-epileptic drugs work in a different manner than older ones. Although many of the drugs we use actually work on sodium channels. Even though they work on sodium channels, the drugs work differently. So they're obviously interacting with that channel in a different way, or doing other things that we don't quite understand. But what's very important is, with experience, we know how to use those drugs in combination. And the good thing is, with the medications we have now, unlike 20 years ago when we had those other meds, we can use them in combination with less adverse effects. So people can take, obviously we prefer to have someone on 1 medicine or 2 medicines, but sometimes we have to go to 3. But there's less drug interactions, and people can sometimes be on 2 or 3 medicines and obtain seizure freedom, particularly if they're not surgery candidates, and then have good tolerability and have good quality of life without a host of drug-drug interactions, or being sedated, or having difficulty talking, or having mood changes, et cetera. And then these are some anti-epileptic drugs. There's actually others that are clobazam and escarbazepine are already available, and then brivaracetam. But there's a few others that are in development. And then Dr. Joby is going to talk about surgical therapy. But what is important is, if you have failed 2 seizure medicines, okay? So fail means that if you have not become seizure-free for 12 months in a row, then you failed the seizure medicine, assuming you've been on a correct dose, et cetera. So once someone has failed 2 seizure medicines at good doses, the chance of becoming seizure-free is about 5%. So that's the point that someone needs to be referred for video monitoring, because what happens is, maybe we have the wrong diagnosis, maybe it's not epilepsy, maybe it's a different kind of epilepsy than what we think, so you're on the wrong medicine. Or 3, maybe surgery might be an option, or some other therapy. Now we've got device therapies that Dr. Joby will talk about. So, and that's why it's important, because the goal is not to become complacent. sometimes we see patients say, well, I'm having 3 seizures a month. But the thing is that that's not okay. And what happens is no one's ever talked to them about other possibilities. Now there's some newer devices, a smartwatch to potentially detect seizures. Some of them are based on heart rate and electrodermal response. Actually, I had one patient, she has seizures where her heart rate increases, and they're at night. And actually, she, having heard of using a Fitbit for a seizure detection, but actually in her case, she could, because you would see blips in her heart rate. There are different things that are in development. Deep brain stimulation, this is where they stimulate deep structures in the brain. This is not available in the US. Trials are done here in the US, but it's approved in Europe. And then Dr. Joby is going to talk about neuropace stimulation. Seizure prediction, this is going to go along with Dr. Joby is going to talk about with regard to seizure prediction, like with, or not seizure prediction, the neuropace device. But what happens is, before a seizure occurs, there are changes in the brain that can occur seconds or sometimes even several minutes before the seizure actually happens. So the person doesn't know that it's happening. Now, we already know if we put electrodes in the brain, we see changes. We can see changes maybe several seconds before the person feels anything, okay? But I'm talking about changes that occur several minutes before. And some people have prodromes, so not an aura like something before a seizure, but a prodrome. And so there are changes that occur in the brain. So there are sophisticated analyses that they do to look at certain frequencies in the brain. And Brian Litt and Greg Roel are 2 people, and John Gottman, looking at these things to try to identify having earlier detection of seizures, and also might tell us a little bit more about epilepsy, how it develops, and also how to maybe attack a seizure with an electrical stimulus way before the person recognizes it. And I actually just a small digression, because again, I said, we learn a lot by keeping an open mind as we try to figure out seizures. And I had a gentleman when I was a neurology resident, and his name was Miguel. And he would call up and he'd say, I'm having my headaches, I'm going to have a seizure. And that was his prodrome. So something was happening. And so I says, Miguel, your headaches are not related to your seizures. You shouldn't have a headache 24 hours before a seizure. So I was a little dense. So after like 6, 7 times, then I'd say, Miguel, when you have a headache, because he would go into a seizure, take some Ativan, and that would prevent that. Or another gentleman who had a prodrome of anxiety on and off throughout the day. This is not common, but what's happening likely in those situations is that the person was probably having little mini seizures on and off and was producing these manifestations, and then subsequently it would culminate into their regular epileptic seizure. There's a therapy that's been available since 1997, vagus nerve stimulator. Dr. Joby will talk about that. Now there's a new algorithm for this where it delivers a stimulus based on heart rate change. Some people have seizures, their heart rate increases. And so this is premised on that giving a stimulus, an electrical stimulus to the vagus nerve, which then goes to the brainstem, can potentially abort the seizure or affect the seizure. Usually vagus nerve stimulator doesn't necessarily work as well on a demand system like neuropace does, but it does help to quell down the overall excitability of the brain to prevent seizures. And Dr. Joby is going to talk about responsive neurostimulator. Now, there's also newer techniques. And Dr. Joby is going to talk about epilepsy surgery and putting in grids and electrodes and all that. And there are newer ways of being able to, so in other words, some patients have more complicated epilepsy where they have to have electrodes placed in, and Dr. Joby is going to talk about that. But there's newer methods. There's this ROSA robot that can help implant electrodes without removing the skull and then putting them into the appropriate spot using MRI, CT, to be able to put them in, rather where the neurosurgeon can put them in, and we can monitor the seizures, figure out where they're coming from, and can be helpful for localizing seizures where they're a bit difficult to identify. And this is just an example of where these are not actually showing you the electrodes, but shows the trajectories of the electrodes, and actually makes it easier for the neurosurgeon to do without a complex frame where a surgeon can put them in within an hour, hour and a half. So where this technology is helpful is people who don't have an abnormality on the MRI, but we have enough data based on EEG and what the seizures look like to map the network to try to figure out where the seizures are occurring. Or some patients have lesional epilepsy close to motor or sensory cortex, language or primary visual brain regions, and we typically, those patients require surgery to put a grid on their brain. Some of these patients can have this procedure done. Patients with two abnormalities, one in the brain and one in the deep temporal lobe. People with multiple lesions. People with temporal lobe seizures come from both sides. And some patients who've had prior unsuccessful epilepsy surgery, or particularly patients who have multiple surgeries that might have scarring, this ROSA robot method of implanting electrodes can be helpful. Doesn't require craniotomy, which means removing the skull. Well tolerated by most patients, low risk for infection and bleeding, and then electrodes are removed without a second surgery, and then a few weeks later the patient comes back for their definitive surgery, assuming we could localize their seizures. A picture of the brain. So when we're localizing seizures, we kind of produce a map of your brain based on EEG, your symptoms, the PET, MEG, SPECT data, and Dr. Joby will review that. And then there's other future therapies, looking at cell therapy, gene therapies, people looking at stem cells, the Jack Parent at the University of Michigan, and then also understanding how epilepsy occurs, which is epileptogenesis, looking how the growth factors influence how the neurons connect, and because when epilepsy occurs, the process that causes epilepsy has been going on for years. So when the person has the seizure, the process has been going on for many years, even before the person had their first seizure. So the goal is to try to identify the early process, and so they look at certain markers, they call them surrogate markers, to try to identify when the process began, and then try to intervene, because oftentimes once the epilepsy's begun, you miss the boat at that point, because the epilepsy is already in process. But the goal is to try to identify those people at risk early on, and then find interventions to prevent epilepsy from starting. And then we've learned in the last several years that some people have autoimmune. So what happens is a person has their immune system attacks the brain and makes them have uncontrolled seizures. And then there's immune therapies we can use for that. We've learned, there was a epilepsy phenome genome project a few years ago, and they got a lot of data from that, from families who had genetic epilepsy. And this slide doesn't do justice. There are many other genes that are identified for epilepsy, different kinds of epilepsy, and not everybody has a genetic form of epilepsy, but this helps us understand the mechanisms of epilepsy. And we also understand that there's, through some of these genes, some of these gene products like these channels, is that certain epilepsy drugs actually make the epilepsy worse. So we know that we need to stay away, like as Dr. Zimba was mentioned, Dravet syndrome, lamotrigine, Lamictal will make those seizures worse. So those patients should not be on lamotrigine. But other medications like cannabidiol oil, Onfi, Strepentol, are medications that actually work pretty good for that kind of epilepsy. And then there are other things that in development, enhanced drug delivery directly to the site that's causing the seizures. So those are kind of some of the directions that we're going in. And this is a summary of our program here. And this is our epilepsy team. We've got obviously epilepsy specialists, neuropsychologists, our nurse surgeon, Dr. Joby, our nursing staff, our superb EEG technologists. And the key thing about our program is that everybody doesn't just do their job, they go above and beyond. And that's what makes the program work. Everybody goes above and beyond. And they go above and beyond because they care. And so there's really a synergy that works here because we're all kind of working together. And it even occurs, it starts even in my office because they really go above and beyond to kind of help the patient, walk you through the process. You're not a number. We're really trying to walk you through the process, try to help you to find a treatment and cure for your seizures. And I'm going to end here because Dr. Joby's got to start. So the key things, I'm going to just end here on a hopeful note. Searching for and finding miracles. What's a miracle? Well, it doesn't mean, a dividing water, but an extremely outstanding or unusual event or accomplishment, sometimes little things, listening to little things, and this happens day in and day out, patient tells me something, or sometimes a student will say something that's very, very intuitive, or we'll find something on EEG or MRI that teaches us something that changes research or the clinical picture in a unique way. But to do that, we have to be very humble. We have to realize we don't know all the answers. We have to be hopeful and have curiosity. We want to learn, and almost like a childlike sense of wonder, try to figure things out. Unceasing desire to learn, find the truth, being obedient. What that means from the Latin, move closer and listen. Always listen to the things, particularly the things that don't make sense and that don't necessarily fit, and to question. And then, always having faith and hope that we can always make a change to make a difference. And I cannot tell you, even the patients that we've treated, by keep on looking and looking, you can oftentimes find the answer. Because the goal here is not only to help you, but to increase the knowledge and database about epilepsy such that we can help all people with epilepsy. And also having courage, and part of that is having a team that encourages each other to help us do the right thing. And also a passion for the disease state, for the people, and to find a cure. And that really, what that consists of, people like you, particularly this staff here in my office and at Bayfront, to work together to be able to help our patients. So I'll end here and hold off on questions. Dr. Joby is going to be next, and I'll take your questions at the end, okay?